Welcome back to The Explainer. Listen, if you're standing in the ICU right now, or maybe grinding through your board prep, you already know that modern medicine is basically magic. But, well, sometimes those miracles come with some pretty terrifying, life-threatening price tags. Today, we're decoding a seriously high-stakes clinical scenario, CAR-T-induced cytokine release syndrome, or CRS. We're going to dig into the pharmacology, the pathophysiology, and those split-second decisions that literally mean the difference between a patient losing their cancer cure or losing their life.
So here's our roadmap for today. We've got 1. The critical case presentation. 2. Unmasking the cytokine cascade. 3. The fatal corticosteroid trap. 4. Tocilizumab, the targeted hero. 5. ASTCT grading and protocol. And 6. High-yield exam pearls. Let's jump in.
All right, Section 1, the critical case presentation. Let's step right onto the ICU ward and meet our patient. We are dealing with a massive, absolutely life-threatening post-immunotherapy complication. We call it the boy who couldn't stop burning. Seriously, if you manage oncology patients, you simply have to know this scenario inside and out.
Okay, let's rapid-fire this presentation, just like morning rounds. We've got Rajan Mehta. He's a 19-year-old guy with B-cell acute lymphoblastic leukemia. He is exactly 12 days post-CAR T-cell therapy, and man, he is crashing. Chief complaint? A persistent high-grade fever for 6 days straight. His vitals are honestly alarming. A scorching 40.4 degrees Celsius, severe hypotension at 82/54, and he's desaturating to 88% even on 6 liters of oxygen. But you know, the biochemical clues tell the real story here. CRP is at 310, and his ferritin, wow, it's over 12,000. Hyperferritinemia of that magnitude, it's a massive red flag strongly suggesting a severe macrophage activation cascade is just destroying his system from the inside out.
Section 2, unmasking the cytokine cascade. Let's figure out the pathophysiology behind this sudden crash.
To fix him, you really have to understand the timeline. On days 0 to 3, we've got step 1. The infused CAR T cells are activating against the tumor cells. This is great. It's exactly what we want. But then we hit step 2, right around days 4 to 7. We get this massive release of IL-6, which basically acts as the ultimate amplifier. And this pushes the patient straight into the emergency red zone by days 8 to 12. That's step 3. The immune cascade just goes into total overdrive. Macrophages activate, vascular leak syndrome kicks in, and the end result is the multi-organ dysfunction we're seeing in Rajan right now. The fever leads to hypotension, which leads right to hypoxia.
Section 3, the fatal corticosteroid trap. With a raging inflammatory fire like this, it is time for a high-stakes clinical decision.
So, time to put you on the spot. Rajan is crashing right in front of you. His organs are failing. What is your absolute next move? Do you reach for high-dose steroids, an anti-IL-6 receptor antibody, or an IL-1 receptor antagonist? Take a second and think about your primary target here. Are you going to go with option A, methylprednisolone, a high-dose IV corticosteroid? Option B, Tocilizumab, the anti-IL-6 receptor antibody? Or option C, anakinra, the IL-1 receptor antagonist? Lock in your answer.
What's so fascinating about this is how it completely subverts our basic medical instinct. I mean, your gut is probably screaming that corticosteroids powerfully suppress inflammation, which, sure, makes total sense in a normal cytokine storm. But the reality? It's a fatal trap. If you give high-dose steroids here, you're going to induce apoptosis in the infused CAR T cells. You effectively erase the million-dollar cancer cure we just gave Rajan. And worse, there's a secondary danger. This non-selective immunosuppression will completely mask secondary nosocomial infections in a patient who is already severely neutropenic. Not good.
Moving to Section 4, Tocilizumab, the targeted hero. If option A destroys the cure, how do we stop the storm without killing the magic?
This brilliantly illustrates exactly why option B is the right call. Tocilizumab is our FDA-approved first-line therapy for severe CAR T-induced CRS. By specifically binding and blocking both the soluble and membrane-bound IL-6 receptors, it just halts the inflammatory cascade in its tracks. But crucially, and this is the key, it spares CAR T-cell viability. The anti-tumor response remains totally intact while the patient stabilizes. It's a win-win.
Comparing these immunopharmacology options side by side, Tocilizumab is definitely our first-line hero for grade 2 and 3 CRS, safely targeting that IL-6 receptor. Now, anakinra is also CAR T safe, but we really reserve it for when CRS overlaps with hemophagocytic lymphohistiocytosis, or HLH. And dexamethasone, yeah, that is relegated to a strict caution zone. It is an absolute back-against-the-wall last resort for refractory or grade 4 cases only.
Section 5, ASTCT Grading and Protocol. Let's see how this pharmacology translates into an actual standardized ICU protocol.
First up, we need to accurately grade Rajan's status using the ASCT consensus guidelines. Grade 1 is basically just a fever. Grade 2 is fluid-responsive hypotension or hypoxia needing low-flow oxygen. But look closely at Grade 3, hypotension requiring a vasopressor or hypoxia requiring high-flow oxygen. Based on Rajan's BP of 82/54 and his need for 6 liters of O2, he lands squarely in Grade 3. Once we have that grade locked in, the protocol tells us exactly what to do. For Grade 2 and 3, we stay in the safe green zone. We give Tocilizumab. Then we wait, about 8 to 12 hours. If there's no response, we can hit him with a repeat dose. We only ever enter that emergency red steroid zone to give dexamethasone if the patient is entirely refractory or escalates to Grade 4. In that red zone, we're talking pure salvage therapy. You're accepting the loss of the CAR T cells because, well, you have to save the patient's life.
Let's get down to the exact ICU mechanics for this. The standard dose for tocilizumab is 8 milligrams per kilogram IV, and that's capped at a maximum single dose of 800 milligrams. You can repeat it in 8 to 12 hours if the clinical response isn't where you want it to be, up to a maximum of 3 doses. But listen, pay close attention to this clinical pearl. You must always draw blood cultures before administration. You absolutely have to rule out concurrent bacterial sepsis because honestly, the clinical presentation can look practically identical.
Finally, Section 6, High-Yield Exam Pearls. Let's consolidate all of this into some key takeaways for your boards and attending rounds. If you see this scenario on an exam, like the NEET PG or the USMLE, here is exactly how they're going to test you. If you see a post-immunotherapy fever with a ferritin over 10,000, immediately think severe CRS. The villain? IL-6 is your primary driver. The next best step for hypotension and fever post-CAR T, boom, administer tocilizumab. And the distractor? Corticosteroids. Eliminate that option immediately unless the question explicitly states the patient is Grade 4 or completely refractory. If you remember absolutely nothing else from this explainer today, remember the golden rule of CRS. Tocilizumab first. It targets the storm while protecting the cure. Steroids last. They are a necessary sacrifice, used only when the patient's life is in immediate refractory jeopardy. Save the CAR T, save the patient. You know, it's pretty amazing how we're using one targeted therapy to manage the extreme side effects of another. But as we look toward the fast-evolving future of immunopharmacology, I want to leave you with this provocative thought. As our engineering of immune cells gets more and more sophisticated, will next-generation CAR T therapies eventually just have built-in off switches? Like, will we even need these aggressive pharmacological rescues entirely? It's something to think about. Until then, though, keep your ASCT grading sharp and know exactly when to reach for your targeted heroes. Thanks for joining me on The Explainer. Keep crushing your studies, and I'll catch you next time.